Hi, my name is Dr. Peter Duboulay. I am professor of radiology and vice chairman of radiology at Harvard Medical School and the Brigham and Women's Hospital in Boston, Massachusetts, and I'll be speaking on ectopic pregnancy. I'll be spending the next half hour on an important topic, the topic of ectopic pregnancy. As you can see here on my title slide, I'll be talking about a variety of different kinds of ectopic pregnancies. The slide on the left shows a live ectopic in the left fallopian tube. The slide on the right shows what we call a heterotopic pregnancy, one inside the uterus, one pregnancy inside the uterus, here we are with a heartbeat, and one in the left cornu of the uterus. The overview of the talk that I'll be giving, I'll be covering both diagnosis and treatment. I'll start out my talk with some basic rules of diagnosis of ectopic pregnancy. I'll move on from there to some pitfalls in diagnosis as well as diagnosis of unusual ectopic pregnancies. And then I'll move on briefly at the end of my talk to discuss ultrasound-guided treatment of ectopic pregnancy. Ectopic pregnancies occur in a variety of locations. The most common location is in the fallopian tube outside of the cornu of the uterus. And that can be in any one of the isthmic, ampullary, or fimbrial portion of the tube. About 95% of ectopic pregnancies in women who conceive naturally occur in the extracornual portion of the fallopian tube. The other 5% of ectopics, although a higher percentage of ectopics in pregnancies achieved via assisted reproductive technologies such as in vitro fertilization, about 5% occur in uncommon locations, including heterotopic pregnancies, which is a combination of a intrauterine pregnancy and a simultaneous ectopic pregnancy. Pregnancies in the interstitial portion of the tube, the portion of the tube that traverses the cornu of the uterus, is another kind of unusual ectopic pregnancies. Cervical implantations are another form. Intra-abdominal pregnancies are rare, and a variant of ectopic pregnancy is a pregnancy that is implanted in the uterus but in a cesarean scar instead of in the central portion of the body of the uterus. And I'll be talking about all of these, both common and uncommon forms. So let's now get into the sonographic diagnosis. We'll first start talking about some of the basics before we get into some of the more advanced aspects of diagnosing ectopic pregnancy. The clinical setting in which ectopic pregnancy, in which we do ultrasounds to look for ectopic pregnancy, are women who have a positive pregnancy test. In other words, a positive beta HCG test. That's the serum pregnancy test. A woman who has a positive pregnancy test combined with symptoms of pain or bleeding is one in whom we, when we're doing an ultrasound, are doing it to rule out ectopic pregnancy. So we suspect ectopic pregnancy clinically in women with a positive pregnancy test and symptoms of pain or bleeding, and we often call such a patient a rule-out ectopic patient. And the key questions, for the reasons that we'll see in a minute, in a Ruleout Ectopic, when we're doing ultrasound in a Ruleout Ectopic pregnancy, are, number one, does the ultrasound demonstrate an intrauterine pregnancy, an intrauterine gestational sac? And the second key question is, are the adnexa normal? The ovary and regions around the ovaries outside the uterus, are they normal? The reason these are the key questions can be seen from this table. This table is based on an article that was published some years ago by myself and Dr. Douglas Brown, who's now at the Mayo Clinic. And what we did was we summarized the data in the literature to come up with the likelihood of ectopic pregnancy in a patient with a positive pregnancy test, symptoms, and no intrauterine gestational sac. In such a patient, what's the likelihood of ectopic based on what we see in the adnexa? And importantly, as you can see from the left-hand heading of this chart, the likelihood of ectopic depends on the extra-ovarian adnexal findings, the findings in the adnexa outside the ovary. And why is it important that it's outside the ovary? Well, in a patient with a positive pregnancy test, anything inside the ovary is likely to be a corpus luteum, so it is largely irrelevant. But what's very relevant is what we see in the adnexa outside the ovary. Again, this is all, as you can see in the heading, in a patient with a positive pregnancy test, symptoms, and nothing in the uterus. So if the extra-ovarian adnexal findings are abnormal, then the likelihood of ectopic pregnancy is very high. For example, if the adnexal findings outside the ovary, if in that area we see a mass with an embryo or a yolk sac, then of course the likelihood of ectopic pregnancy is 100%. We've seen the ectopic. What about a Ruleout Ectopic patient in whom we don't see an embryo or yolk sac in the adnexa, but we see a lesion outside the ovary that is surrounded by a bright ring called a tubal ring? And we'll see examples of all of these in a minute. Then the likelihood of ectopic pregnancy is 95%. If we see in a Ruleout Ectopic patient any complex or solid mass in the adnexa outside the ovary and outside the uterus, the likelihood of ectopic is slightly lower, but it's still over 90%. If we see free fluid with nothing else, as long as it's at least a moderate amount of free fluid in a Ruleout Ectopic patient, in our analysis we couldn't give a number, but we know that the likelihood of ectopic is quite high in a patient with a moderate to large amount of free fluid, positive pregnancy test, symptoms, and nothing in the uterus. Now at the bottom is the situation in which our patient who has a positive pregnancy test, symptoms, nothing in the uterus, also has nothing in the adnexa, at least nothing outside the ovary. So there may or may not be an ovarian lesion, but we ignore those as corpus luteums. So if the adnexa outside the ovary is normal in such a patient, the likelihood of ectopic is far lower than when the adnexa are abnormal, but it's not zero. In other words, if we see a Ruleout Ectopic patient, we see nothing in the uterus, nothing in the adnexa, the likelihood of ectopic is down at about 5%. So it's fairly low, but not anywhere near zero. So based on these numbers, we can put together the following diagnostic algorithm or diagnostic chart. If we start with a patient, a Ruleout Ectopic patient, one with a positive pregnancy test and symptoms of pain or bleeding, the first test would be an ultrasound. And the first question to ask when we do the ultrasound is, do we see an intrauterine gestational sac? If the answer to that is yes, an ectopic pregnancy is virtually excluded. The chance of ectopic, if there is an intrauterine pregnancy, is well under 1%, probably under 0.1%. Doesn't mean that we shouldn't look for it, but to all intents and purposes, the identification of a pregnancy inside the uterus rules out a pregnancy outside the uterus, an ectopic pregnancy. If we do the ultrasound in this Ruleout Ectopic patient and the answer to is there an intrauterine gestational sac identified as no, we don't see one inside the uterus, then the key question is there an extra ovarian mass, an extra ovarian complex or solid mass? And then the possible answers to that question are yes, there is one with a yolk sac or an embryo or yolk sac. So if we see a complex mass outside the ovary in the adnexa with an embryo or yolk sac, we've diagnosed a definite ectopic pregnancy. Likelihood is 100% of ectopic because we've seen the embryo or yolk sac. If the answer is yes, there is a mass in the adnexa, but there's no embryo or yolk sac, then the likelihood of ectopic is not quite 100%, but it's very high, over 90%. And finally, if we see nothing in the uterus and nothing in the adnexa, then we don't know where we stand. The differential is ectopic pregnancy, as we saw from the prior table. There's about a 5% chance of ectopic. Or it can be an intrauterine pregnancy that's either a failed pregnancy, and that's why we're not seeing it, or a normal intrauterine pregnancy that's just too early to see. So if we put this algorithm or this diagnostic chart into a table, we get the basic rules for ultrasound diagnosis in a Ruleout Ectopic patient. And here are the basic rules for ultrasound diagnosis based on what I've shown you up to this point. If the ultrasound finding in a Ruleout Ectopic patient is an adnexal mass with a heartbeat or yolk sac, our interpretation is definite ectopic pregnancy. If the ultrasound finding is an adnexal mass outside the ovary without a heartbeat or yolk sac, we have a probable ectopic. If there's a moderate to large amount of free fluid in the pelvis, we also have a probable ectopic in this patient, again, that has positive pregnancy tests and symptoms. If the scan is normal, and that is with or without an intraovarian lesion, so the normal means nothing in the uterus, nothing in the adnexa outside the ovary, then our interpretation of the ultrasound should be a possible but unlikely ectopic pregnancy, about 5%, or we could say can't rule out an ectopic because the chance is 5%, but it's low. And finally, if we see an intrauterine pregnancy, then ectopic pregnancy is virtually excluded. But we would still check the adnexa to see what we see. So here, the next several slides will be some ultrasound examples of these basic rules. Here's a definite ectopic pregnancy. There's a live embryo outside the uterus. Here's the uterus on a transverse or coronal transvaginal view of the pelvis. And here in the left adnexa, we see a fluid collection surrounded by a bright ring called a tubal ring. But more importantly, we see an embryo inside. And how do we know it's an embryo? Because on this companion video, we can see there's a heartbeat inside. So this is not just a probable ectopic pregnancy, it's a definite ectopic pregnancy because we're seeing a live embryo outside the uterus. Here's another definite ectopic pregnancy. Woman comes in with a positive pregnancy test, pain, bleeding. We do an ultrasound, and on the ultrasound, we see nothing inside the uterus, but here in the left adnexa, we see a tubal ring, fluid collection surrounded by a bright ring next to the ovary but not in it. And importantly, inside the tubal ring is a yolk sac, seen here. So because there's a yolk sac, this is a definite ectopic pregnancy. There's a gestational sac with a yolk sac in the adnexa. This is an example of a tubal ring without an embryo or a yolk sac, nothing in the uterus. There's some free fluid, but very importantly, here's the ovary. But beside the ovary, outside the ovary and beside it, we see a fluid collection surrounded by a bright ring called a tubal ring. Because there's no yolk sac or embryo, we can't say there's 100% likelihood of an ectopic pregnancy, but it is highly likely, over 90% chance of ectopic because of the tubal ring. Here's another Ruleout example of a Ruleout ectopic patient where we see nothing inside the uterus, and in the adnexa, that's the edge of the uterus, there's the right ovary. Between the ovary and the uterus, we see a solid mass. What is this solid mass? Well, we don't know for sure what this is. It could be an infection, it could be a tumor, but because this is a Ruleout ectopic patient, in other words, she has a positive pregnancy test and some pain on that side, when we see this solid mass, that likely represents an ectopic pregnancy. So she has an over 90% chance of having an ectopic pregnancy because of this solid mass. Another woman comes in with a positive pregnancy test, pain, bleeding, and we do the ultrasound. We see nothing in the uterus, but in the adnexa, or in the pelvis outside the uterus, we see a large amount of free fluid and clot. Here we are on a transverse or coronal view, transvaginally, lots of free fluid and some clot. In view of the fact that we see a large amount of free fluid and clot, this woman who has a positive pregnancy test has a very high likelihood of having an ectopic pregnancy. So I've gone over the basic rules of diagnosing ectopic pregnancy. Life isn't always so easy that we can apply basic rules. There are some problems or pitfalls that one can run into in diagnosing ectopic pregnancy. I said earlier that there are two key questions when we're doing an ultrasound. Number one, does the ultrasound demonstrate an intrauterine gestational sac? And number two, are the adnexa outside the ovary normal or not? Each of these has some pitfalls when we try to answer them. In some cases, there's some problems. So first, does the ultrasound demonstrate an intrauterine gestational sac? A potential pitfall here is confusion between a gestational sac and what's been termed a pseudo-gestational sac. And we'll get into that in a few minutes. And the second question is, are the adnexa outside the ovary normal? Well, it's not always so easy in real life to distinguish an intra-ovarian from an extra-ovarian lesion. There can be confusion between the two, leading to difficulty or a pitfall in answering this question. So let's take a look at these potential pitfalls. Here are two patients with two Ruleout ectopic patients. They have positive pregnancy test, pain, bleeding. They come for an ultrasound, and two different patients, but similar findings. In each one of them, we see a little fluid collection in the uterus. I would call it, these are so-called non-specific fluid collection. What do I mean by non-specific? Well, they have little rounded edges. There's no double sac sign. DSS is double sac sign. There's no intradecidual sign. There's no yolk sac. There's no embryo. Just a little non-specific fluid collection in the uterus in these women who came in for Ruleout ectopic patients. So when you look at them, one question might be, is this a gestational sac sitting here outside of the uterine cavity, which is a collapsed cavity and a gestational sac, or is it just some fluid inside the uterine cavity, which would be a so-called pseudo-gestational sac? It makes a very, very big difference. If we say that these are pregnancies, intrauterine pregnancies, then the patient would go home and be told that she has no ectopic pregnancy. On the other hand, if this is fluid in the uterine cavity, namely a pseudo-gestational sac, then there would be great concern for ectopic pregnancy, and she might be treated with medications such as methotrexate for an ectopic pregnancy. So how do we deal with these nonspecific fluid collections in a Ruleout ectopic patient? How do we know whether they're gestational sacs or pseudo-gestational sacs? Interestingly, on both of these patients, a week to a week and a half later, when each of these two women came back, these nonspecific fluid collections turned out to be pregnancies. You can see on these videos of each of them that there's a week or week and a half later, there's an embryo with a heartbeat inside the uterus. So how could we tell at the earlier date that these were pregnancies when they didn't have any special features of pregnancy? So the potential error that can happen here, and unfortunately I've seen this error occur too many times, is that a woman might come in as a Ruleout ectopic patient. The ultrasound shows a nonspecific fluid collection. The interpreter, the doctor interpreting the scan, says this is a pseudo-gestational sac. The patient gets treated with methotrexate, and that ends up damaging an intrauterine pregnancy. The potential consequence of mistaking these fluid collections for pseudo-gestational sac is that the patient may receive a treatment that damages the pregnancy, such as methotrexate or DNC, either of which can damage an intrauterine pregnancy. So how do we deal with these? Well, before we get to that, here are a couple of examples of where I've seen such misinterpretation leading to major problems. This is a woman who came in as a Ruleout ectopic patient to a hospital other than mine. I saw these only after the fact. A woman had a 5-week scan for pelvic pain. She had a positive pregnancy test, and the ultrasound was read by someone else as showing a small fluid space in the uterus, that's this thing, and a small cyst adjacent to the left ovary, that's this thing, and some free fluid, that's this black area in the adnexa, and the impression of the interpreter was a left ectopic pregnancy because of the cyst and free fluid with a pseudo-gestational sac in the uterus. So this was said to be a pseudo-gestational sac. Because of that reading, the woman was treated with systemic methotrexate for her presumed ectopic pregnancy. She had a repeat scan 4 days later, and now it showed that this was actually an intrauterine pregnancy because there was 4 days later a yolk sac. But the problem is this intrauterine pregnancy had been damaged by the methotrexate given 4 days earlier. The outcome was a miscarriage or failed pregnancy, likely because the methotrexate damaged the pregnancy, leading to miscarriage, and the follow-up to that was a malpractice lawsuit for damaging this pregnancy by misreading it because of a misreading, calling this a pseudo-gestational sac. This is another similar example. A woman had a 5-week scan for pelvic pain, and this was seen. Instead of, the reading was, I'm not sure what it is, and because of that, she was given systemic methotrexate. On a repeat scan just 2 days later, a yolk sac was seen, but again, meaning that this is an intrauterine pregnancy, but again, like the last case, this intrauterine pregnancy had been damaged 2 days earlier with methotrexate because of a misreading of this scan. And the outcome at birth was the baby was born with multiple anomalies, likely because of damage from the methotrexate. And again, there was a malpractice lawsuit. And this one happened at my own hospital as almost as what we call a near miss. Fortunately, there was no problem, but there almost was. This is a woman who had an ultrasound at 5.5 weeks of pregnancy based on in vitro fertilization retrieval dates. The scan was read as fluid but no gestational sac in the uterus. Can't rule out an ectopic. This was done somewhere else near my hospital. She was sent in to my hospital to get methotrexate for her presumed ectopic because this was felt to be a pseudogestational sac. We repeated the scan at the hospital and we reviewed the outside scan, and we said this looks like an early intrauterine pregnancy, and so fortunately she didn't get methotrexate and went on to have a normal pregnancy. Because of all these errors that we've seen, I together with Dr. Carol Benson, who's in charge of ultrasound at the Brigham, wrote an editorial called First, Do No Harm to Early Pregnancies. And we said that any of these small fluid collections in the uterus in a patient with a positive pregnancy test have to be interpreted as being intrauterine pregnancies, or almost certain intrauterine pregnancies. And we did a little calculation in our editorial. We assumed that if the incidence of ectopics in all pregnancies is 2%, and a double sac sign or intradecidual sign occurs in half of intrauterine pregnancies, and a pseudogestational sac occurs in 10% of ectopic pregnancies, then if we do a little calculation, we determined that a nonspecific fluid collection in a woman with a positive pregnancy test that nonspecific fluid collection has an over 99% likelihood of being a gestational sac and a less than 1% likelihood of being a pseudogestational sac. So when you do an ultrasound on a Ruleout Ectopic patient and you see one of these little nonspecific fluid collections, you should say in your interpretation, this is almost certainly an intrauterine pregnancy, not a pseudogestational sac. And therefore, if you say that, the pregnancy will not be damaged by treating it with methotrexate. So in a woman with a positive pregnancy test and a nonspecific intrauterine fluid collection, the fluid collection is almost certain to be a gestational sac, very unlikely to be a pseudogestational sac. So the takeaway message is that in a patient with a positive pregnancy test, any fluid collection with rounded edges in the central part of the uterus must be interpreted as having a very high likelihood of representing a gestational sac. The exception would be fluid that's clearly within the uterine cavity, like this. You can see it's right in the center and has these pointed edge here. Similarly, another woman here has some fluid in the mid-uterus, a little pointed edge. These are not those rounded edge collections that I'm talking about. These are just pseudogestational sacs, but anything else has to be interpreted as being an almost certain ectopic pregnancy. And your report, if you want to stay out of legal trouble, as in this little diagram of somebody in big legal trouble, your report should state there's an intrauterine fluid collection that is highly likely to be a gestational sac. And treatments that could damage an intrauterine embryo, such as methotrexate or D&C, should be avoided at least until definitive intrauterine pregnancy is definitively excluded. Now, what about pitfalls of the second question? Are the adnexa normal? Here again, as I mentioned earlier, the potential pitfall is confusion between intraovarian and extraovarian lesion. And these are examples. Here are 3 women who had ultrasounds to rule out ectopic pregnancy. They had a positive pregnancy test, symptoms, and they had nothing in their uterus. And when we look in the adnexa, there's the ovary, and there's a lesion that looks like a tubal ring, but it's right up against the ovary. And it's hard to be sure whether it's outside the ovary, or maybe it is inside the ovary just projecting out a little bit. Maybe it's just a corpus luteum projecting out. Similarly, does the ovary end here, and that's a tubal ring of an ectopic pregnancy, or does the ovary end here, and this is inside the ovary? And similarly here, does the ovary end here, or is this inside the ovary? So not always so easy to distinguish an intraovarian corpus luteum versus an extraovarian tubal ring of an ectopic pregnancy. On follow-up, these two turned out to be ectopics, and this was the patient had an intrauterine pregnancy. So how do we tell when we see a mass up against the ovary? If this is a Ruleout Ectopic patient, positive pregnancy test symptoms, there's the uterus with nothing in it, there's the ovary, there's a mass. Is this in the ovary? Is that the ovary, and this is a corpus luteum? Or is this outside the ovary? Does the ovary end here, and that's a mass beside it? Well, one way to tell when we're doing a transvaginal ultrasound is to press and see if it moves together with or separate from the ovary. And watch what happens when we press. Here you can see we're pushing in and out with the transvaginal ultrasound transducer, and you can see there's the uterus, there's the ovary, there's the mass, and if you look at the junction between the mass and the ovary, the mass slides against the ovary. It doesn't move with the ovary. Therefore, we can say this mass is extraovarian. It's beside the ovary, not in it, and therefore this patient has an almost certain ectopic pregnancy because she has her positive pregnancy test symptoms and an extraovarian mass. This is another similar case. A woman has a positive pregnancy test and symptoms. We do the ultrasound. There's nothing in the uterus. There's the ovary. There's a cyst in the ovary. And there's a mass. Again, is this a corpus luteum within the ovary, or does the ovary end here? And like in the last one, when we push, you can see at the junction between the mass and the ovary, they don't move together. The mass slides along the ovary, so it's beside the ovary. Therefore, she has an extraovarian mass. This is an extraovarian tubal ring. She has an ectopic pregnancy. Talk briefly about some unusual ectopics, including abdominal pregnancy, cornual ectopic pregnancy, cervical ectopic pregnancy, heterotopic pregnancy, and cesarean scar implantation. Abdominal pregnancies are situated in the abdomen, outside the uterus and outside the tube, just free in the abdomen, typically up right against the intestines. These are usually, but not always, that easy to distinguish from intrauterine pregnancies. Here's such an example. This is a 15-week pregnancy. 15-week pregnancy, there was a live embryo. There was a heartbeat on another view. Here's the pregnancy. And at first sight, this patient was experiencing very extreme pain. At first sight, the ultrasound could be interpreted as showing an intrauterine pregnancy. This could be interpreted as the cervix, and this as the intrauterine pregnancy, with no explanation for her pain. But when we looked a little more carefully, you could see that this was actually the whole uterus. When we moved the transducer a little bit, there's the top or the fundus of the uterus, and this pregnancy is just sitting free in the abdomen. Cervical ectopic pregnancies are ones that are implanted in the cervix, and there the potential difficulty is separating it from a spontaneous abortion in progress. The difference, we diagnose a cervical ectopic, one that is implanted in the cervix instead of one that's passing through it, is if we see a nice well-formed gestational sac with a nice bright ring around it, especially if we see an embryo with a heartbeat. If we see a flattened sac without a nice bright ring around it, no embryo or heartbeat within it, we diagnose a spontaneous abortion in progress. So if we see a well-formed sac with a prominent bright or echogenic rim, especially if we see a live embryo, we call it a cervical ectopic. If it's a flattened irregular sac, thin or absent rim around it, no live embryo, we call it a spontaneous abortion in progress. If it's equivocal, we're not sure which of these two it is, and the patient is clinically stable, we'll wait 1 or 2 days. If it's unchanged, we'll call it, we diagnose cervical ectopic, and if it's gone, it's a spontaneous abortion in progress. And these are examples side by side. There is transvaginal view of the uterus, and here's the cervix. Nothing in the body of the uterus. In the cervix, we see a gestational sac with an embryo and heartbeat. This is a very well-formed sac with a embryo and heartbeat. The only problem with it, it's a big problem, is that it's in the cervix. This is a cervical ectopic pregnancy. Here, on the other hand, we see another transvaginal view, nothing in the body of the uterus, a flattened sac in the cervix. There's not a bright rim around it. We see a little yolk sac, but no embryo. This is a spontaneous abortion in progress. And here's one where we weren't completely sure. This woman was having pain and bleeding, nothing in the body of the uterus on this transvaginal scan. Here in the cervix is a gestational sac. We weren't quite sure whether it was a pregnancy implanted here or passing through it. Spontaneous abortion in progress, so we said, let's scan again tomorrow. She was stable. The next day it was all gone. So this was a spontaneous abortion in progress here that had cleared out. When we're trying to diagnose corneal ectopic pregnancy, the challenge is distinguishing a corneal ectopic pregnancy from a intrauterine pregnancy that is located off to the side or eccentrically located, or an intrauterine pregnancy in a duplicated uterus like a bicornuate uterus or a septate uterus, in which you have two horns, one with the pregnancy and one without the pregnancy. There's some similarity in appearance of all these, and I'll show you examples on ultrasound in a minute. The key difference, we diagnose a corneal ectopic when we see no myometrium. Myometrium, or the muscle of the uterus, looks dark compared to the tissue around the gestational sac. If we see no myometrium and bulging of the edge of the uterus, we call it a corneal ectopic. So if there's an eccentric gestational sac with little or no visible myometrium, which shows up as hypocoque tissue around the superior or lateral aspect of the gestational sac, we call it a corneal ectopic. And if there is myometrium around the entire gestational sac, it's an intrauterine pregnancy. A few examples. Here is a corneal ectopic pregnancy. We have, here's the uterus. The pregnancy is way off to one side. There's bright tissue around it, but then there's no dark myometrium around the outside. And we see it again here. There's the heartbeat, there's the main body of the uterus, there's bright tissue around it, nothing around the far edge. That's a corneal ectopic pregnancy. Here is another patient. She has something that looks quite similar. The pregnancy is way off to one side. This is a coronal or transverse view. But there is myometrium all the way around the outside. This is an intrauterine pregnancy in a bicornuate uterus. Here's another corneal ectopic. This is in the left horn of the uterus, the left cornua of the uterus. Gestational sac, bright ring, no dark myometrium. It bulges the edge. Sometimes we can get a more clear-cut or definitive view using 3D, three-dimensional ultrasound, and here on the three-dimensional ultrasound, that's the fundus of the uterus. There's the left cornu or left horn of the uterus, and that's where the pregnancy is. It's not inside the body of the uterus. This is a corneal ectopic pregnancy that we were pretty sure of on the regular ultrasound and become completely sure on the 3D ultrasound. Here is a case where it's not so easy to tell. We have a pregnancy, it's way off on the side. There is little or no dark myometrium around part of it, but it isn't really bulging the edge of the uterus. If we're not sure, we should always wait. because the last thing you want to do is damage what might be an intrauterine pregnancy. In this case, we were very glad we waited. We actually, a few days later, did a 3D ultrasound. This is the same pregnancy sac as that, way off on the side. But you can see on some of these extra views from the 3D ultrasound that it looks like there is myometrium all the way around it. And we were glad we waited. At 13 weeks, it was a nice normal intrauterine pregnancy. So from the last two cases that we saw, it's not always so easy to tell. This one looks something similar to that one. This was a corneal ectopic. This was an intrauterine pregnancy. So we have to treat these with great care. If we're not sure, we get a follow-up ultrasound a day or 2 or 3 later, which will usually give us the answer. So I've come to the end of the tour. I've looked at some of the basic rules for diagnosing ectopic pregnancies, some of the pitfalls in diagnosing tubal ectopic pregnancies, and some of the rules for diagnosing unusual ectopic pregnancies. I hope that it's been very useful to you in seeing how we make the diagnosis of tubal and unusual ectopic pregnancies. Thank you.